Monday. Are there any questions or things that I have left out that you're looking for? All right. So today it's kind of a potpourri of stuff. We're going to talk about general anxiety disorder, obsessive compulsive disorder, and insomnia. So the good thing is that the majority of treatment is with drugs we've already been over, so there's nothing new to learn. But we are going to talk about the benzodiazepines, which will be a new group that we haven't really ever talked about before. So, with a lot of these disorders, the drug is, even though people may go to it first, it's really not the first line. So first line is usually the cognitive behavioral therapy. It is as effective as the drugs and is kind of seen as the foundation piece. Usually it's much better long term. All of these drugs carry a lot of side effects with them, especially the benzodiazepines in terms of tolerance, dependency, and withdrawal symptoms. So we really want to move people towards better coping with the disorder that they are facing. So I understand you've been through, you've had an orientation to cognitive behavioral therapy, correct? Correct. Okay, new face. Sorry, didn't see her. Is she with you, Sophie?
Yes, this is my shadow, Michelle. Hi.
Michelle, where are you from?
I'm from Tulsa originally, graduated from OU in May. So,
What was your degree?
health and exercise science.
Health and exercise science. Okay. You'll get none here if you become a PA. There's none in this program. Okay. Are you working in that field
Yes.
right now?
So I'm a scribe and a home health aide right
Okay. Okay. So lots of good terminology
Yes.
use. Okay.
now. Definitely a learning curve.
All right. Well, we're happy to have you today.
Thank you.
Thank you. Okay. So tell me what you've learned about anxiety. You probably experienced quite a bit of it. So what have you learned about general anxiety disorders?
It's more of an anticipation of a possible threat than an actual fear of something specific.
Okay. So it can be just the worry about something that will take place. How does it manifest? What kind of symptoms would people come and talk to you about?
Racing heart.
Racing heart. Okay, so it can have some very physical symptoms. What else? Sleep disorders. Yes. Can't sleep, can't get to sleep, can't stay asleep. What else?
Like a tremor. Is that part of it? Like if you're shaking.
Okay, so some more of the somatic symptoms. Okay, what else? Sweating goes along with that, so a lot of autonomic functions can come in, or symptoms can come in.
Nausea.
Nausea, okay, so lots of symptoms. How does it tend to play out? Have not all of you experienced that to some degree? Then why don't we put you all on drug? So it has to interfere, so how would that interference look? Okay, so it really cuts into your productivity, ability to do work, task of daily living, carry out home or social responsibilities. What else?
Maybe like stimuli. So like we get nervous for tests, but someone with an anxiety disorder would be nervous about multiple things, nothing specific.
Okay, and what might that lead to? What might they do in order to decrease that? Avoidance. So avoidance to the point where they avoid solving a problem or engaging. So avoidance is one of the things that drugs can help with. What else? And agoraphobia might be the extreme of that. You talked about that, so you might just avoid all contact outside of a space you can control. What else?
They might use like alcohol or drugs to treat themselves.
Okay, so they might use other things that would help short-term decrease those symptoms and cause us real problems when we try to use medication, because those can have amplifying effects, negative effects. Anything else? So socially, it can inhibit their interactions with folks. We've got avoidance that we talked about, decreasing function or productivity, relationships. Okay, good. What's the extreme of anxiety? How does that manifest?
Panic attack?
Panic attacks. Okay, so we're going to talk about those as well, and how to treat those. Okay, very good, very good. I think Dr. Britton's earned his pay, and you all have got the information. That's good. You all have told me more things. Now, why have you been able to tell me more? No, I'm really curious, because sometimes I come in and you all can't recall anything. And that just may be time of day, and sometimes we have distance between when it's presented and when I actually show up. So why is it different?
He shows videos, I think that's pretty helpful.
The videos, okay. So how does that help?
Just visualization.
Visual, puts it in context, you see it played out in a real person.
It's
Okay.
more fun.
More fun. Fun always makes things better. Look at kids. How do kids learn early on?
Play.
Usually through play. So you see a lot of play activities introduced in, especially 3, 4, or 5-year-olds. So see, we never really change. I told you Sesame Street had it right. You know, they change it up every 10 or 15 seconds. New music, new sounds, new characters on TV, new color. It helps. Our brain, we get bored pretty quickly. Yeah. Okay, so let's look at the medicines for GAD. So there's lots of them. The antidepressants are the foundation piece. They're the go-to drugs. We can use anxiolytics. We can use them as monotherapy when a person does not have depression, even though depression and anxiety tend to be comorbid conditions, so they tend to occur together. So these other anxiolytics or the anticonvulsants sometimes can be used to augment a partial response to a antidepressant, or they can be used alone, especially if somebody can't tolerate an antidepressant, will take the antidepressant. So that's their place. They're kind of a second line. Antihistamines can be used. Hydroxyzine is kind of a favorite go-to, particularly if there's no depression, sleep is a problem. It's a good or mild anxiolytic, commonly used. Don't have any tolerance dependence problems. And then the second generation antipsychotics are beginning to be looked at. Quetiapine has an indication for that. That would be something, though, you can see that as you're starting to study all the side effects of the second generation, there's a whole host of things that come with them. So they really are, you've exhausted everything, still need a drug, then you look at the second generation. So that's how these all kind of fit. So with for the antidepressants, the SSRIs are considered the go-to. You can also look at the SNRIs. The ones that are listed here have randomized controlled trials as evidence. Probably all of them would work, but these are the ones that have the most data. I've listed those at the bottom: paroxetine, sertraline, citalopram, and escitalopram. So they're all efficacious, so how do we choose between them? Some of it may be that it's chosen for you because of what their medical or their prescription plan will pay for. Could be the drug side effect profile. You certainly should appreciate that in these last week and a half, is that how heavy the side effects are with these drugs. And so that may be the best thing you can do, is kind of match those up for people when you're first choosing, if you have the ability to choose. The other is drug-drug interactions. You've seen that. There's lots of very significant ones that can occur. It may be that the patient's been on there. Remember I told you sometimes when a patient would come in, they are having depressive symptoms, but they've been on something in the past, they lost coverage, they quit it, whatever happened, and they had a good response. I'll usually go back there. yes, I like that, yes, it worked fine, I ran out of money, couldn't afford the copay, so you get them restarted. Or I thought I didn't need it anymore, and obviously I do, but I don't have a prescription for it. Something, that history might come into play. So for the place in therapy, these drugs are good for the psychic symptoms of anxiety, so the apprehension and the worry. We're going to see that the benzos tend to focus on different symptom clusters that they are good at. Since we usually have comorbid anxiety and depression, whenever that are present together, then antidepressants will always be the go-to if we need a medication. If the symptomatology is mild and the patients are fairly cope well, it may be that there's no drug needed and they need to be put into therapy. Or some patients may be drug averse, and they may be very willing to go to therapy. Sometimes people are willing to go to therapy, but their symptoms are so overwhelming that it's helpful if you use the drugs to get their symptoms under more control. Then they can be more responsive or maybe more cooperative with therapy. So there's all kinds of ways to think about it, so it's very individualized. Looking at what the patient needs, what's their current status. Older patients, you're going to see a lot of anxiety and depression play out in the elderly. These drugs are terrible when it comes to the older folks. The symptoms are magnified, and their renal and their liver functions start to come into play. So with the elderly, it really is important to use very low doses and titrate them slowly. And then look, bringing in your caseworkers or your behavioral psychologist or someone who can address the social situations that will impact a lot of what the elderly are dealing with. It may be a loss of a spouse, it may be a loss of a home, maybe they've had to be relocated, maybe they've lost control over what they used to have, maybe status has gone down. Maybe they just have got a lot of diseases they have to deal with and they just don't want to deal with them anymore. So bringing in people who can help with those and help them in adjusting, their social support system or how they're actually living. Maybe things that would go further than the drug itself, that the drug can't fix. Okay. Benzodiazepines are frequently been used in anxiety. They have probably been the go-to drugs. I'm kind of gone back to place in therapy, that third bullet. So benzos have been kind of the drug that people have used. But because of their tolerance, because of their abuse potential, because of their withdrawal symptoms, they have gone down in status. And our SSRIs are much better, and we have studies to show that those work better. That's another reason why we prefer those agents over the benzos. Okay. So the top of page 2, the doses that you will use with the antidepressants are similar to what you would use for for depression. And the response is going to be about the same. It's still going to be a delay of about 4 to 6 weeks before you see effects. So sometimes dealing with that first 4 to 6 weeks when you are putting them on a drug, some of these drugs are activating, so their anxiety just gets worse. So we're going to talk about how do you address that, what do you do with it. So start slow. You've got to have some kind of documentation of what their symptoms are. I've posted about 4 different scales on your D2L that you can look at. Sheehan's disability, have you talked about it? The other one's going out of the other name is going out of my brain. But you can use these as a way to at least get a baseline and then document those. Those are going to be what's going to help you in terms of determining response. So they kind of look at response in terms of, is it robust, is it partial, or is it minimal? Now, how those things are described are kind of loose. So robust would be their symptoms go either way down or go away. So the sweating, you all talked about, the heart rate racing. It may be then that their functionality goes up. I don't miss as many days of work. I'm able to keep my house. I'm able to keep my social responsibilities. I'm sleeping better. So those would be the things you're going to be looked for as response. So robust is, wow, they are like a different person, or they're telling you, I feel like myself again. Partial is going to be some improvement, but not quite. It still is impacting their ability to function, do their job. So then we would look at treating them a little bit different. Minimal is going to be some response, but very little. So it's kind of a relative grade that the patient probably needs to tell you. And you need to also then have a kind of an objective way of saying, okay, they were complaining of not being able to get out of the house 5 days a week, and now they only stay in the house 2 days a week, something like that. Okay. So I'm not going to go back over the adverse effects of the SSRIs or the SNRIs. I'll just refer you back. If you study those and I asked a question that was related to anxiety, it's going to be it isn't going to change at all. You can use SSRIs, you can use SNRIs. They're considered equal in efficacy in terms of general anxiety disorders. So that's our mainstay. 4 weeks, 4 weeks is about right for the patient to see significant, or to start to reach a point where they should see improvement. 4 to 6 weeks may be needed to, if they're showing some improvement, but not as much as you would like. So then looking at second-line agents. So there's 2 second-line agents. One is Buspar and the other is pregabalin. So buspirone is a serotonergic receptor antagonist. It focuses on the 1A receptor. Most of the other ones we talked about were more active on the 2A receptor. So it's thought that that's probably why this agent is not as effective in treating depression, but it's a really good anxiolytic. So think of this as augmenting therapy. You can use it as monotherapy if anxiety is the main problem and depression is not. But you can add it on to other antidepressants. But it has serotonergic activity, so what are we going to be worried about?
Serotonin syndrome?
Serotonin syndrome, because if you're on a serotonergic agent, an SSRI, and you're putting them on something like Buspar, it's commonly used together, but it would be something to kind of keep in mind as you're starting to add serotonergic drugs into the mix. So when to use it, if patient has a partial response to maximally tolerated SSRI. When I put SRI, I mean either SSRI or SNRI. Or they've had 2 trials, minimal response, then this would be another time to consider it. If the patient's been on a benzodiazepine before, it's not as quick in onset as like a short-acting benzo. So letting the person know, again, we need about a month to start to see the effects of what this drug is going to do. Typical side effects are more activating, like insomnia, agitation, nausea. The nausea, remember, those serotonergic receptors are in the gut, so it's a common nausea, vomiting, upset stomach, common with the serotonin agents. Another agent that can be used to augment is pregabalin. So the pregabalin is very similar to gabapentin or Neurontin. We talk about it all the time. This one goes by Lyrica. There's commercials all the time on TV for it. Also can be used with any of the SSRIs or SNRIs. Again, the same, about 4 to 6 weeks to evaluate the effect and determine whether it's going to work or not. The advantage here is that it doesn't, it has less tolerance, doesn't really have much withdrawal potential. Dependence is there, but it's low, very low compared to the benzodiazepines. Less addictive, much better tolerated than the benzodiazepines. It is a Schedule 4, or what is it, 5? No, it's a Schedule 4, sorry. No, the benzos are 4s, Lyrica is a 5, I believe, yeah. Sorry. Side effects. Here the side effects are sedation, dizziness. Gait disturbances are very common in the elderly in terms of like when they get up and then from a resting position and they try to walk. They may have some really odd neurologic motions for a while until they kind of get into their gait. Let's see. Different mechanism of action. If you're worried about serotonin syndrome, this would be a one to try. Especially in your younger patients, and when you don't want to use a benzo. So remember this one, it's a little bit odd. It's very effective. Okay. Page 3. These are the drugs to consider if you have resistance. That's how they term it, medication resistance. So you're not getting effects to your first and second line agents that we just talked about. So this is when we use the benzodiazepines. This is a big class. What have I told you about big classes of drugs?
Popular.
There's usually a great need or demand for them, right? The other good thing with that is that they are a very diverse group. You have very short actors, you have medium actors, you have long actors. So their kinetic differences we can take advantage of, and we do. When we're treating insomnia or we're treating anxiety or other disorders, we can take advantage of that. They're all equally effective anxiolytics, and they're very good at it. They are the drug of choice in an acute anxiety situation. The very rapid short actors can reduce anxiety within a matter of minutes. So they can be effective when the patient is acting out or having aggressive behaviors. So they can be used for acute, they can be used for maintenance. They're just not preferred anymore because of the tolerance and the withdrawal that we've talked about. And they can be used long-term in patients who have very low abuse potential or have very low withdrawal. Or they don't have breakthrough symptoms in between dosing periods. So there are some people who are very good candidates for it. Okay, going down to that kind of next big paragraph. They can be used by themselves as monotherapy. We don't do that very often. They can be used as an adjunct to the antidepressants. They have a different mechanism of action, so they don't tend to amplify the problems with the SSRIs. Often, I told you that, or if you'll go back and look at your SSRIs, we talked about some of them being activating, that the patient actually gets more agitated, they have more insomnia when they first start the drug. Usually that goes away over time. If that happens, if you put somebody on an antidepressant and their anxiety increases greatly, then using a short-term benzodiazepine is very helpful because that will bring that agitation down and can buy you time until the SSRI or the SNRI can take effect. The problem is that then you have to gradually wean them off of it. So it isn't a quick, put them on, 4 weeks later, they're doing well, take them off. You have to always taper a benzodiazepine. Because the longer you use it, the more conformational changes you make in the GABA receptor, and it takes longer and longer for the body to come back to baseline or to normal. Okay. So benzodiazepines are more effective for somatic symptoms and autonomic symptoms. you mentioned a lot of those. So the somatic are the restlessness, fatigability, they're worn out all the time, difficulty in concentrating, irritability, muscle tension, sleep disturbances. So they're great with that. Autonomic symptoms, you all mentioned a lot of these. Shortness of breath, heart racing, palpitations, the sweating, the dry mouth, the dizziness, abdominal distress, those complaints that go along with anxiety. They're good at this. Okay. So you see that we talked about the antidepressants are good with the psychic symptoms. So these are really a great combination. They can just be hard to deal with long term. Let's see. Wait on that. So who's a good candidate for benzodiazepine treatment? And this is looking at more long-term treatment, but they're listed there. People who have chronic anxiety, they have a minimal of depressive. So the anxiety is the predominant, depression is not, is the major focus. They don't have a history of substance abuse disorders. That'd be really important in your history to determine that. They haven't developed tolerance to their anxiolytic. Some people develop tolerance very quickly. Some people also have withdrawal symptoms. They're very sensitive to it. So if you're using an agent and they have withdrawal in between dosings, those are usually not good people to look at for long-term benzo use. So poor candidates are those who've got a history of substance abuse. They develop rapid tolerance. So you would tell that by the fact that they constantly need dose escalation. The other would be is that they escalate the dose without you telling them. They just keep their own self-titration going. And then the withdrawal between. So those are folks that if you're going to use them, you use them for a short period and you move them off. You wouldn't leave them on long term. Questions about those or comments? Okay, let's go over to page 4. So these drugs affect the GABA receptors. So GABA, you have to kind of think in the negative. GABA is an inhibitory neurotransmitter. Okay, so when we use a benzodiazepine, we potentiate that, we prolong that. So a lot of the excitable type of symptoms that are related to anxiety, that's why they go down. You increase that inhibition. So GABA are membrane receptors that modulate mood changes, anxiety, sleep, memory, mood, analgesia. We do have an antagonist for it, flumazenil. When we get to ER and we do a lot of withdrawal and drug toxicology, I'll talk more about that. But just to mention, we do have an antidote for it that we can use in an overdose situation. Let's look at the kinetics because you can use the differences to your patient's advantages. Some of them have very rapid onsets. I've only given you 4 here. There's quite a few more, but if you look at alprazolam and lorazepam, their onset is very quick. Their duration is short. If you look over there at their half-life, that is considered short. Compare it to diazepam, which has a rapid onset, but look at its half-life, 50 to 100 hours. And in renal and liver impairment, it's even longer. We used to use another drug in this class called chlordiazepoxide or Librium. It was a favorite to use for patients who came in alcohol withdrawal. And when we would give them that drug, if you didn't space it out and watch them, you could put those people to sleep for weeks because their half-life would be so long. I saw it happen to one guy one time where they didn't decrease the dose in light of in appreciation of his liver impairment. And that guy slept for, what I remember is at least 2 weeks. That was before DRGs, we could keep them in the hospital as long as they want, but he just didn't wake up because the drug dose was too high and he couldn't eliminate it. Drugs with short elimination half-lives have increased risk of withdrawal. Okay? So alprazolam is one of the highest with withdrawal. The longer acting tend to have, and the short acting have very quick onset, so we use them in that situation. Like midazolam, we use that for surgery where we're going to put somebody to sleep. We'll use that to induce that very quickly. Or if we're going to do a procedure, we can do it because it's quick and lasts very long, makes you amnestic, you don't remember anything, you wake up and you don't remember anything. Sometimes that's a good thing. And then the elimination, for very long elimination half-lives like diazepam and clonazepam down there, those are slow in onset, so you're not going to use them necessarily when you need something quickly, but for maintenance or when you are having patients with experience withdrawal or breakthrough, then the long actings would be preferable. Let's see. Questions about those? Okay, let's go through the side effects. And there are quite a few. I've just grouped them into several categories. This is usually with longer term use. Psychomotor retardation. So remember, these are inhibitory. So drowsiness, very common. All of them will cause drowsiness. Poor concentration, mental confusion. You can see where some of these can then confuse the picture because some of these are also symptoms of their anxiety disorder. Ataxia, motor coordination, muscle weakness, double vision, dizziness. Slow reaction time. So in driving or operating heavy machinery, that can be a real problem. So being aware of what your patients do or warning them about driving, especially your elderly. The risk of being in an accident would be high. Memory impairment. This one's easy to remember because we use these drugs to impair memory when we want to do something to them that could hurt them or cause them greater anxiety. They have impaired memory in these three areas. One is remembering recent events, so their short-term memory is impaired. The circumstances under which something occurred can be impaired, and the sequence of events can be disturbed for them. In people who use it longer, remember, the longer it goes, usually the more severe the side effects will become. Their visual spatial ability and their ability to have long-term attention also decreases. That's in people who've had it or taken it for more than a year. Then you get these paradoxical disinhibitions. It's thought that it is actually allowing other circuits like the adrenergic circuits to become dominant. And so you see symptoms like increased excitement, irritability, agitation, hostility, impulsivity. They can have rage actions, violence, antisocial behaviors can occur because of that. You damp down one thing that kept them in check and the rest of it then is exposed. Depression can get worse, emotional blunting, suicidal ideations are possible. So keeping those in mind for your long-term folks. In terms of pregnancy, they are considered a class D. So X is the one where they're absolute teratogens, D are likely teratogens. They have evidence of them, so we don't want them to be used in pregnant women. They do cross the placenta. They will cause a tolerance and a dependence and withdrawal symptoms on the child when they're born. And they also should not be used in women who breastfeed. They easily cross and can be delivered in quantities high enough to also cause those things in the breastfeeding child. Last is dependence. There's a physiologic dependence. They have a physiologic withdrawal and a psychological dependence. The shorter acting agents, the dependence occurs faster, more quickly. And the more high potency. Alprazolam, very, very effective, but is a very potent, short-acting anti-anxiety agent. Withdrawal symptoms, that should say emerge instead of emerge. So withdrawal symptoms with a rapid dose reduction. So you cannot quickly or rapidly take them off these drugs, and because that'll precipitate. The longer they've been on it, the faster it will precipitate symptoms. The psychological become the anxiety that goes up when you tell them, I'm going to start tapering you off. Over-reliance on it, putting faith in it, and then the anxiety that would come when they are taken away. Can result in drug-seeking behaviors, buying it on the streets, getting it from others, stealing it from others, going to multiple providers to get the agents. Comments or questions about those? Okay, let's talk about withdrawal. It's important to be able to recognize the symptoms of benzodiazepine withdrawal because they can be life-threatening. So they can be a medical emergency. So counsel your patients about not stopping them abruptly. I see this with alprazolam quite a bit, is that it's a very sedating drug, and so it's hard for people to take it during the day. So they may quit it, or that you'll have folks who, they know they need the drug, but they really don't want to take it. They don't want to become addicted. So maybe when they've been really symptomatic, someone has put them on it, but they want to be off of it. So Xanax is one of those that really, the withdrawal symptoms can be as severe as seizures, can lower their seizure potential and produce new onset seizures. So the symptoms of benzodiazepine withdrawal are tremors, their anxiety goes back up, perceptual disturbances, so the way they perceive things is out of balance to what is actually happening or with reality. Dysphoria, psychosis, and then the seizures. The onset will be dependent on the half-life of the drug. So the shorter the half-life, the more quickly they will occur. With long-acting, like diazepam, you may not see withdrawal until several weeks after you've stopped the drug, because it takes that long for it to be eliminated from the body. So keep that in mind, those kinetic differences when you're dealing with those products. Some of what I've got left down there, I'll just be repeating myself. So let's look on top of page 6 and look at how to withdraw. Withdrawal needs to be individualized, go slow, and gradual. So I've given you two different approaches. One recommendation is to decrease the dose by 25%, wait a week or two, reduce it by another 25%, then you're down to 50%, and then do about a 10% reduction over every couple of weeks. So a withdrawal can take you up to 6 months to accomplish. Others go much more slowly. They do a 10% reduction every few weeks. If a person has been on a benzodiazepine before and had withdrawal symptoms, then going slower is the right way to go, and looking at it over a 6-month period. Sometimes employing, if they have not been through or it's stepping up that cognitive behavioral therapy while they're doing it can be very helpful. Questions about those, about the benzos? Okay, we'll finish up this page and we'll see how we may go a little bit further before we take a break. Another antidepressant that can be used is mirtazapine. It's one of those atypical antidepressants. It's a very sedating antidepressant. So if you have someone who has a lot of anxiety or insomnia, it might be one to consider, especially if you don't want to use another product with it, or you've got contraindications to your other augmenting type drugs. Vistaril, hydroxyzine, antihistamine, very sedating, used commonly for sleep-related disorders, insomnia. It's very effective, can be used easily in most people, but it is an antihistamine, and it has a lot of anticholinergic effects with it. So in your elderly, you'd want to be careful in using it with them. In the other things, the higher the dose would be the dry mouth, blurred vision could be a problem. And then quetiapine, we talked about resistant general anxiety disorder. You've used everything else. You could use it in combination with a antidepressant, or you can use it as monotherapy if the other agents cannot be used. Questions there? Okay. The next few pages are, next 3 pages, take what we've just talked about and then put it in a treatment flow. So we'll start through that. We'll take a break here about 10:12. So goals of therapy. So our goal of therapy is we want to make the patient functional. We want to reduce the symptoms that are interfering with their abilities and restore them to as much functionality as they can. We want them to sleep well, want them to be able to do their work, and engage socially and in other responsibilities that they have. And we like to put them into remission with as few anxiety-related symptoms as possible. Realizing that this can take a 1 to 2 year process in terms of with therapy and with the use of the drug. Because usually by the time we get to a year, we will usually treat these folks for at least a year and then entertain starting to taper them off. Especially if they've have successful therapy, then they may be at the point where they can handle this disorder with just the tools that they have used and without drug or minimal drug. Let's see. Some things under general approach just to keep in mind. We talk about this from time to time, but it's true for almost every approach to treating a disorder that we have, is to keep in mind the severity of what you're dealing with, how old the person is, what's their renal function, liver function. Always, we're going to do that. I've always encouraged you to figure out a creatinine clearance until you've got lab, or if you feel like you need lab to confirm it. Look at their side effect profile. This is big for these psych group because they're so, not devastating is not the word, but they're common and they can be severe. They can be as worse as the disease you're trying to treat. What's been their past response? Again, patient preference. What do they desire in terms of what are they looking for in drug, and then cost. So the newer agents are really expensive, and so like Dr. Britton told you the other day, they may push you, the insurance may push you towards those less expensive agents. Well, they usually have more side effects, and so there's always that balance. Again, drug therapy, cognitive behavioral therapy, both effective. Which one you choose is going to be dependent on the patient, what they're willing to do. Combination is also okay. It may be the best early on, so that the person can take advantage of therapy. You can treat with drug first, follow it up with therapy if the patient is more willing or more receptive, or can pay for it. Depending on their insurance, because it can be, how long is usually cognitive behavioral therapy?
So it can be months. it depends on what you're treating. You know, for phobias, it can be as short as several sessions, or it can be as long as months. It really just depends on the disorder.
Most of the insurances that I have dealt with usually will pay for like 12 sessions,
Yeah, 4
psych
months.
sessions in a year. So that's not a lot if you're, depending on how often they want you to be there.
Yeah, I was talking to him earlier, maybe not today, but a little bit earlier before, that a lot of patients who have need, personality disorders, some of these
Yeah.
phobias, these anxieties, if you're like senior care Medicaid, they can't get the real therapy, so you're pretty much left with drugs. So that's why they're on your doorstep. There's no other way to make it better. So the system traps you, and this is true for private insurance too. There's a limited number of sessions. Some people are outside that boundary before they get treated.
Psych issues in your Medicaid population will just drive you nuts from this standpoint. When the psychiatrists get a hold of them, they pile them on drug. And they'll put them on all the newest agents they can. And so they eat up all your ability to prescribe drug for the patient for another instance. Let's say they have diabetes, which they commonly do, or hypertension, or lipid disorders. There's no way to pay for them because the psych meds, usually they are on 4 to 6 psych meds. So one of the jobs we did is we did a lot of work with how do we lay the drugs out in terms of how often they can be filled so that we can maximize their Medicaid. So about the most we could ever do is get up to about 12 drugs that we could then have them fill every 3 months, every 2 months, or we send them to Walmart on the $4 list, or we could send them to the, in Oklahoma County, there is a county pharmacy. And county pharmacy is like a last stop. If you've used up all your Medicaid and you have no other way to afford medicines, then county pharmacy will step in and will provide some. So it's a lot of coordinating, trying to get patients' medications filled in a way that will keep them as healthy and functional as possible. Comments there? Dylan, Sophia, what did y'all see in the pharmacy? Did it ever affect you all?
If you're.
Because they'll come in and they have a new script, but there's no, we used to call them punches, I don't know what y'all call them now.
Yeah, for adults, it's only 6 a month.
It's 6, but it's only 3 brand and the rest have to be generic.
Well, sometimes that doesn't even apply to, depending on how expensive the medication is generic. Sometimes we have to
Oh, give me
like,
an example.
I can't provide a specific example, but I just know that people would ask me, it doesn't matter if it's brand or generic, and I would always say, it just depends. So
Oh,
sometimes
okay.
we would have to run certain things and discontinue certain things and switch
Yeah.
just to
So I
get-
thought it was just brand, it was just brand, it didn't matter about cost. So an expensive generic could fall into that? Really?
That would, what I remember about that is antibiotic capsules. Sometimes, those can be like $60 without insurance,
Yeah,
and that would fall into that category.
wow.
But if you're a kid, the rules don't apply to you.
Yes, now, that's true, it's the adults.
And so another trick is trying to get the 3-month pills, get the 100 tablets for once a day,
Yeah.
to try to roll it over so you could do a punch. I think it was like 100 units, and it was a once-a-day medicine. That was 3 months and 10 days.
It's 100 units or 34-day supply, what is it? There's,
I think it's just
It's,
like.
it's the number of units. If your units are great and your dosing frequency
if it's a
is
4
small,
time a day, then you
what
can
do
get
is you can get a bunch of medicines, but they're on a rolling basis, so that QD thing is always an advantage.
It'll drive you nuts. Talk to your pharmacist, they usually have good tricks about how to lay those out. Okay, let's take a break, we'll come back at 11 and pick up with